Bismillah ar-Rahman ar-Rahim. Today's presentation is about a very common neurological disorder that we come across in our clinic on a very regular basis. It's not only the neurophysician, but also the GPs, primary care physicians do come across this medical condition very frequently. So it is very important to understand headaches, causes, management, and prevention. And I will try to give my perspective about headaches. I would like to start with a case whom I saw a few years ago. She was a 36-year-old female with a complaint of headache and vomiting, presented in the emergency department for evaluation. She did have prior history of headaches for 7 years, and her husband recently moved her out of his house. So she was stressed. She recently felt some fever and sore throat. There was history of sensitivity to light and sound in the past, but not during this current headache. She was feeling slow and poorly responsive to questions by the doctor in the emergency department. On examination, the doctor on duty noticed neck stiffness. When he called me, I suggested lumbar puncture for evaluation based on the neck stiffness and recent fever and sore throat. After this, I had a chance to go to emergency department and I swing by the patient to have a look. And what I came across is that she was feeling depressed and feeling sleepy, but she was having pain on flexion. It was not truly neck stiffness. Based on her prior history and absence of the red flag signs, I gave her a migraine cocktail. She felt improved and went back home the same day. So this particular case highlights the importance of history and examination and making sure about the red flag signs, which is very important to understand about secondary headache or the serious causes of headache. Another thing I noticed was the absence of or unavailability of fundoscope in the emergency department to assess the fundi. I usually carry my own fundoscope, so I had a chance to look at the fundi. I felt comfortable, and then routine management helped her, and we saved her from getting the lumbar puncture, which could have been an extra damage, or that is not nice to do a test which is not required. Let's start with the type of headaches. So according to ICHD classification, headaches are divided into primary headaches, secondary headaches, and neuropathies, facial pain, and other type of headaches. So primary headaches are the most common type of headaches, and out of those, tension type headache is most common. But these patients usually don't present in the emergency department or come to clinical attention as frequent as migraine patients are. So the most of the patients we see in our clinic, as per a study, is almost 70% of the migraine patients. The rest could be tension type headaches and rest of the headache syndromes. Trigeminal autonomic cephalgias is a particular type of headache syndrome. There are other headache disorders which could be related with cough, some other problems, or exercise-induced headaches. And there's a whole classification on ICHD website, and you can review that to understand it better. Secondary headaches, as the name depicts, is related to some other problem, and headache is a secondary manifestation of those problems. Neuropathies, facial pain, and other headache syndromes are separate. Now, coming to the secondary headache, there are many causes of that, but to understand it better, if there is any issue related to the face, neck area, or some other problem in the brain vasculature, it's gonna give you headache. So as it is related with something else, so it is called secondary headache. And as what we commonly see is trauma and injury is a very common cause of headache. There could be vascular issues like carotid dissection or hemorrhage that can give you headache as well. There could be non-vascular intracranial disorders. Headache could be attributed to substance abuse or its withdrawal. As my case shows, it could be related with infection like meningoencephalitis. Headache could be attributed to the disorders of homeostasis. It could be attributed to other neck and face structures, including eyes, ears, nose, cervical structures. So to understand the secondary nature of headache, we need to assess the rest of the face and the neck area as well. And headache attributed to the psychiatric disorder. Also, we need to have that history. It really helps if all the red flag signs have been ruled out, then it could be related with the psychiatric disorder. These are American numbers. So even in US, it has been noticed that almost 40% of the patients are dissatisfied with their migraine management, or they have been non-compliant with medication. Almost 22% of the patients receive migraine-specific treatment. So despite all the evidence-based practice and up-to-date knowledge, still there are a lot of patients who are not getting step-by-step or appropriate medication that suits their migraine type. There is a very common use of opiates and barbiturates, which is close to 22% according to the study. But I have seen a lot of prescriptions in Pakistan where patients are given opiates, and it becomes really hard to take them off. And according to the evidence, is evidence class B, so there is not a strong evidence about using opiates and barbiturates for migraine headaches. So I would really like my GP and a neurologist colleague to avoid opiates as much as possible, and also try to focus more on the migraine specific treatment and counsel the patient so they can stick to the treatment that is advised to them and don't fall out. So to understand the red flag signs better, there is an acronym with the name SNOOP4. It stands for systemic signs and symptoms of disease, which is mainly related to either immunocompromised status or malignancy. So if there is a history of night sweats, weight loss, or fever and chills, we need to look into those reasons to make sure the headache is not related to some immunocompromised state. The other red flag sign or reason for secondary headache could be neurological signs and symptoms. If the patient is having focal neurological deficit, pulsatile tinnitus, history of seizures, new onset weakness, or cranial nerve dysfunction, that could be the reason that the patient is having focal neurological insult. If the headache is sudden in onset, when we say sudden in onset, it has to be in like seconds, which usually happen in subarachnoid hemorrhage, RCBS, pituitary apoplexy. So a lot of serious causes are related with the onset of the headache. If the patient is old, especially more than 50 years of age, there are chances of secondary causes of headache, or if there is a change in the pattern. So when it comes to the pattern change, it could be positional worsening of headache. There could be prior history of other disorder which can cause some a new headache, like a history of breast carcinoma or something else. Or there could be related with the pregnancy state or postpartum status of the patient. So all these changes put the patient in a category where there is a high possibility of secondary headache. We also need to understand, out of all the patients who have headaches, only 2% of the patients have secondary causes for the headache. And almost the patients who are presenting for attention in the clinic or emergency department, almost 18% of the patients have some serious or secondary cause of headache. So it's a very small population of patients, like 2%, but still we need to make sure that assess these patients so we don't miss them out. So there is a condition called status migrainosus when the headache lasts longer than 72 hours. Usually in this case, using simple medication will not help or break the pain cycle. They continue to have headaches again and again. So they need IV medication to break that pain cycle. So we need to understand and communicate this concept to our patients as well. And otherwise, they will keep taking opiates, other medications without relief. So when these patients get IV medication, always make sure that they're not going to change the pain scale from 8 or 6 to 0. It may go down to 1 or 2, which is good enough to send them home with on a maintenance treatment, because it will take another 24 to 48 hours to be totally pain-free. So what I usually recommend to my patients and I try to follow in my clinic is a very good counseling and a stepwise approach. So in a stepwise approach, what you have to do is a detailed history and examination, do assess for the comorbid conditions, like if there is a history of cancer in the past, any infection recently. If needed, then investigations can be done. If it is advised or needed, then I will usually do MRI brain. I usually don't go for CT scan because of the low sensitivity and specificity to look for the causes of headaches. So if I will recommend my GP and a neurology colleagues, if they ever ask for an imaging in headache patients, please do MRI brain. CT scan has added risk of radiation, especially given in females and kids. There are possibility of cancers in the future. So I'm very careful about advising a CT scan to my patients. So unless it's a trauma history or there is possibility of intracranial hemorrhage, I usually never go for a CT scan of the brain. If we are planning to do IV medication on these patients for status migrainosus, urine pregnancy test should be done, or at least confirm the last period of the patient and confirm that they are not pregnant at this time. ECG can be done in these patients who are getting IV medication because there could be cardiac arrhythmia related with some medication. If there is a prior history of ischemic heart disease, having an ECG beforehand could be helpful. And as I said, I usually counsel my patients very well about avoiding opiates, adequate fluid hydration, and also I do combination IV medication. So most of the time what I've noticed in Pakistani practice, that most of the patients go to emergency department or clinic and get an intramuscular injection, which does give them some relief, but then headache bounce back. So they need to get a combination of IV medication to break that pain cycle and stay in remission. So there are a couple of rescue treatment approaches which can be used. Most of them are IV or intramuscular, and few oral can be tried. So most importantly, intravenous hydration, I really stress upon. It is as good as medication. So don't underestimate it and do judicious hydration of these patients. Do advise the patient to drink plenty of water afterwards as well. Antiemetics can be used, and those are very helpful for breaking the pain cycle. Antihistamine is usually used in combination. Patients sometimes complain a little bit of side effect with IV antihistamine, but those are very helpful in breaking the acute pain cycle. Parenteral NSAID, especially ketorolac, can be used. Valproic acid, I have noticed, very helpful in these patients, and it can be repeated if needed. Magnesium in a good dose is very helpful. It should be avoided in patients who are pregnant because of the fetal skeletal abnormality. Triptans, ergot alkaloids, we very well know about those, but there could be a challenge, especially in patients who are having vasculopathy or vascular spasm, because in that case, there could be worsening of their vascular spasm, and there could be distal gangrene or cardiac ischemia. Calcium channel blockers can be used IV. Intravenous anesthetic like lidocaine can be used, and baclofen can be tried on these patients. So there are newer treatments available in the market. Those are not yet available in Pakistan. So there are CGRP antagonists, which can be used. There are DTANs, which can be used as well. But those are very expensive, not currently easily available in Pakistani market, but these are can be tried in our patient as well. Coming to the prevention, which I would like to stress upon in this presentation, because guiding the patient about regular sleep schedule is something very important. And that really helps with the keeping the patient in remission for their headache. Regular meal times, avoidance of high intake of simple carbohydrate food, adequate hydration, and the restriction and consistency of caffeine intake. Mainly it's the caffeine withdrawal which gives worsening of headaches. So they need to gradually taper down or reduce the dose of caffeine they take on a regular basis. Regular aerobic exercises are very good for healthy lifestyle, but also for the migraines. Biofeedback or meditation or prayer are very, very reasonable in these patients. So these patients need to have the control of themselves. So there's a lot of psychological support is needed, and they need to feel in control for their medication management and to understand their migraines and headaches better. So we need to make them feel from powerless to powerful. We need to stop catastrophizing these patients. Cognitive behavioral therapy can be helpful with the help of the psychologist. Usually patients who are coming in with a possible tension type headache, or there is a lot of psychological or stress factor involved, I usually refer these patients to psychologists and try to do these maneuvers beside using medication, because otherwise medication only will not be very helpful in these patients. So meditation, isometric neck exercises. So on my YouTube channel, there is a video for the isometric neck exercises. It takes just 1 minute and should be done up to 10 times a day to have a good relief for at least 4 to 6 weeks. Especially for the patients who are having cervical radiculopathy induced headache or some other cause of neck pain that could be helped by this. Reduce caffeine intake. I have some patients who noted very good improvement with the gluten intake reduction. So that should be tried as a resort to help these patients. And then tyramine-rich foods and reactive hypoglycemia could be one trigger for these patients. So understanding the trigger, understanding the precipitating factors is very helpful in managing long-term these patients. I like to use magnesium very frequently in these patients. It does help with the menstrual migraine. It can be started in a 400 milligram dose and can be titrated up to 1200 milligram. IV infusion is also helpful in acute migraines. But as I said, IV infusion particularly should be avoided in pregnant patients. Oral medication can be used in pregnancy, but patients should be guided about the possible, despite it hasn't been noticed, about the side effects or fetal side effects of the medicine. The other possibility could be CoQ10, riboflavin in appropriate dose could be very helpful. Feverfew, butterbur. Patients who are having MTHFR mutation or migraine with aura and migraine with MRI changes, folic acid with a combination to reduce homocysteine level could be helpful. These patients can be referred to pain clinic for acupuncture. That could be another way to handle the headaches, or cupping can be done. Oxygen therapy, capsaicin can be tried as well. So in summary, recognition of the headache syndrome is the key to long-term management. History and examination are the basic to decide further management. So I like to give some really good time to my patients in clinic to understand the background and guide them accordingly. Recognize red flag points in the history and examination, and making sure that we get the appropriate investigation, imaging, or a blood test to make sure what's going on, or lumbar puncture. Avoid opiates as much as possible. Hydration is as valuable as medication. Low dose has better efficacy and tolerability. Rarely admission may be needed to monitor the response to treatment and avoiding complications. I hope this presentation would be helpful for my general practitioner colleagues who see a lot of these patients, and also for some neurologists for some basic refresher for headache. Thank you very much.